I mean, every time I talk about robotic surgery, the person looks at me and says, so, where are you going to be? You're going to be in the coffee shop and just have the robot do it? And I have to explain that robotics isn't artificial intelligence taking over of you. Robotics is the use of highly sophisticated mechanical arms and mechanical instruments that the surgeon controls at a console at the bedside. I'm Dr. Nick Nissen. I am a surgeon, a liver and pancreas surgeon, and I am the director of the liver transplant program, and I am director of the Hepatobiliary surgery at Cedars-Sinai Medical Center. That whole part of the body, the liver, the bile ducts, the pancreas, those are all within a few inches of each other, and they're connected both by proximity, by shared blood vessels, and by other shared structures. And they do share some function. The bile from the liver passes through the so-called bile duct and then passes through the pancreas. And so one of the most common symptoms of pancreas cancer is when the bile duct is obstructed by the pancreas and then you turn yellow, and that's jaundice. And jaundice is thought of as being a liver condition, but in this case it starts from a pancreatic condition. So they're all very, very intricately related. Well, one of the biggest problems we have with pancreatic cancer is finding it early. It is one of the toughest cancers to treat, and it's one of the toughest cancers to beat. It's a cancer that's actually on the rise. And part of the problem is we're finding it at later stages, which means that the chance for cure really hasn't gone up that much. Pancreas cancer is really only considered curable at its early stages. In the later stages, it's a fight for time, and you're fighting to control the disease, but the chance of being cured of it drops quite a bit. So there's a couple ways to treat pancreas cancer. Surgery or removing the tumor is still considered to be the best chance to be actually cured. So the goal is, at least in earlier stages, is always to remove the affected part of the pancreas, either the so-called head of the pancreas or the tail of the pancreas. And chemotherapy is always used along with surgery. There's a little bit of ongoing debate about which strategy is better. Sometimes chemotherapy is given after you remove the tumor. Sometimes chemotherapy is given before you remove the tumor. I love being a surgeon. Surgery has the unique opportunity, and I really think it's a blessing. The unique opportunity to have science and compassion and healing and technical skills and ingenuity, and even sorrow, loss, and joy, all added together in your daily work experience. Seeing the cancer from the inside and seeing how it affects organs and seeing the anatomy of this disease. And again, as a surgeon, you've got that opportunity, maybe not that often, but that opportunity now and then to get them across the finish line. So 20 years ago, pancreas cancer pretty much was a tour de force surgery and maybe some chemotherapy later. That was the era where the Whipple surgery, or that's the biggest operation we do for pancreas cancer, was really coming into the forefront. But the general approach was try to get the tumor out with this big heroic surgery, hope for the best. And then gradually over time, we learned that you got to give some chemotherapy if you want the best results. The problem is the chemotherapy that was given was pretty weak. What's new recently is new types of chemotherapy. Some of them are old types of chemotherapy that have made their way now into the pancreas cancer field. Some of them are brand new actual types of chemotherapy. And surgeons are now more and more advocating for a chemotherapy first approach, or what's called neoadjuvant therapy. But we're using now robotic techniques, laparoscopic techniques, standard old-fashioned open abdominal surgery techniques, and we're complementing that with a whole bunch of other things: external beam radiation, implantable brachytherapy seeds, injectable forms of chemotherapy. So IRE, which is also known as nanoknife, stands for irreversible electroporation. It's a way to treat tumors with electricity that is important because it allows treatment of tumors that are wrapped around blood vessels. You can electrocute the tumor and kill it without damaging the blood vessels, or without permanently damaging the blood vessels. Sometimes called multidisciplinary tumor boards are really just trying to take the conversations that used to occur in the hallway and used to occur in the cafeteria and putting them all together at one time, so there's a shared information, shared understanding, and shared benefit and shared even growth of the group that's treating the disease. Surgeons add to that by giving some understanding to the group about How big a deal is the surgery? How fast is the person going to recover? What are their likelihood of complications? How's this going to affect their quality of life, their lifestyle, and even their length of life? And they can contribute by advising when is the right time to intervene with surgery. There is a hereditary component to pancreas cancer, and if you have a first-degree relative, and certainly if you have multiple first-degree relatives that have had pancreas cancer, you should have genetic testing, genetic counseling done. We're not real good at figuring out how to screen for pancreas cancer because it's uncommon enough that just telling everybody to get screened at a certain age is not a very good use of resources. But if you're in a high-risk group, then you should be screened at an early age. So what does the future hold? The future holds us getting smarter about the weak links of pancreas cancer, smarter ways to attack it. There's more exciting pre-treatments, there's more exciting treatments after surgery, and there's even some exciting tools we use right during surgery. So again, we do think the future's bright for pancreas cancer.